Welcome to the Private GP podcast. I am Alia Shakir, CEO at Walk-in Clinic. Today, we are very lucky to be joined by Dr. Mohseyni, one of our senior GPs, and we are going to be talking about a test. It's a blood test called Prostate-Specific Antigen test. You may have heard about this test, or you might have heard about it as a PSA test, and it's known to be a screening indicator, isn't it, for prostate cancer? And I thought it would be really helpful for people to know a bit more about it. And also just learn a bit more about the statistics and the genetic connections with prostate cancer more generally. So thank you very much for joining us to talk about this today.
Thank you very much. So yes, as you said, PSA is something that often comes up in discussion. A while back, one of the BBC TV presenters was diagnosed with terminal prostate cancer, and he came and talked about it. And after that, we had a rush of people coming to the doctors and asking for PSA tests and things like that. I think it's important to sort of know about this test a little bit more. It's not an ideal test by any means, but that's the best test we have. Talking about the sensitivity of this, unfortunately, the way the PSA test is that you may have problem with the prostate, but your PSA test could be normal, completely normal, or otherwise you could have normal PSA levels, but normal prostate. So it goes both ways. That's why when we do the test, we talk to patients about the implications of that. And because sometimes as soon as the PSA levels come back raised, it causes distress to people. So we have to explain these things to people. There are things that could cause the PSA levels to go up when there's no problems at all. So one of them is if you have an infection in the prostate gland, which is called prostatitis. If you have a simple urinary tract infection, that's something which could increase the level. If a gentleman has had recent ejaculation, last 24, 48 hours, that could increase the levels as well. And so is any procedures like inserting a catheter, urinary catheter, or even vigorous exercise. So people who cycle a lot or go to the gym. And,
I've heard about that. Like if you spend a lot of time on a saddle, yeah.
Absolutely. That could sort of show the prostate raise when there's absolutely no problem with the prostate. And there are some medication that we use. For example, when someone has overactive bladder, we use some medication or have slightly enlarged prostate, which could be benign. And we use that to help with the urinary symptoms. Those medication could actually halve the PSA level. So we have to be mindful when we do the test, look at the medication that the patient is taking, and then interpret that in the context of the medication and the patient's history.
That's so important because, I mean, I'm not here to sort of have a go at, other blood test providers, but there are providers where you just pop in, do the test, and they send it to you, and it's either normal or it's high. And then you're sort of left floundering about the result, or something significant could be missed. So this clinical context is really, really important. And so generally speaking, I think it's correct that if you have any concerns in relation to prostate cancer or your prostate, this test ideally should happen in the context of a consultation with a GP or context of, say, a health screening or something like that, where there's an opportunity to gather that kind of information. And as you say, it's not a perfect test, but it's part of a picture building toolkit, isn't it? Which will indicate whether or not, for example, further investigations might be required or a referral to a specialist, for example.
Yes.
And so let's say someone does have an elevated PSA and, based on the clinical context you've gathered, it's, you're a little bit, I need to look into this a bit more. What usually happens next in terms of investigation?
So the sort of general rule is if you're not sure what's the reason for raised prostate, we usually refer that to a urologist, where there would be additional tests like a special type of MRI takes place, which looks specifically at the prostate to exclude any problems, and if needs be, there would be a biopsy. But generally speaking, if there are any grounds to think that this PSA might be raised, but due to other reasons, the best thing is to make sure that the patient observes conditions and then comes back in a few days or a couple of weeks to repeat the
yeah, exactly,
PSA, and then make sure that that's a true
right
raise.
Because you can see trends then, can't you?
That's
is it going up, is it going down, is it normalizing? That's really helpful. The fact that it's such a simple blood test is really helpful, because repeating it and just checking and seeing how things are going seems very, very sensible. So tell me more about the correlation between, say, a high prostate-specific antigen result and a cancer diagnosis. Sure. Is that common?
They do reckon around 25% of people with raised prostate only have prostate cancer. So 75% may not.
So let me just get that straight. 75% people who have prostate cancer will not have a raised PSA?
No. So,
or the other way around?
The other way around. So one in 4 people who have raised prostate, they may have prostate cancer.
Right. So 1 in 4 people who have a higher PSA may have prostate cancer. Well, that's very significant, actually.
Yeah, 25%. And 1 in 6 people who have high PSA, with normal PSA, they could have prostate cancer.
Oh, that's also very significant, and hence back to the importance of this clinical context that we've been talking about.
That is correct. Yes.
Wow.
Yes. So there are lots of debates about the screening. To my knowledge, there are 3 places in the world that they do a screening for prostate cancer. One of them is Lithuania, the other one is Kazakhstan, and recently, I believe, Republic of Ireland has started doing that for high risk category. And there are a certain group of people who are at high risk that we tend to suggest that they do these tests and come and have examinations. And one of them are people from black race. They are at higher risk in general. The cause is not known, unfortunately, but that's something that we often says.
I've seen the recent government campaigns encouraging black men to test more. Yeah. Okay.
So the lifetime risk for developing prostate cancer in a white person is around 1 in 8 people. Well, this is double, isn't it? 1 in 4 in black people. So that's quite significant. And it becomes more significant if someone's father has prostate cancer, because the risk will then double there.
Right.
And if someone's brother has prostate cancer, the risk becomes 3 times.
My goodness.
More.
So the genetic factor is super
Very
big.
important.
So when someone is considering their general health screening behaviors and habits after a certain age, and we could talk about what age you would recommend that to take place, they really need to think about their family history, don't they?
Absolutely. So people who have family history of prostate cancer, they're encouraged to be more vigilant, and we often see that in our health checks, routine health checks.
And you were saying before we started as well that there is also a connection with on the mother's side as well, right?
That's right. So recently there's been more emphasis on the BRCA2 gene. So people who...
And just to be clear for everyone, that's spelled BRCA.
BRCA2 gene, yes. That's a mutation seen in some people with breast cancer and ovarian cancer. So if someone's female, first-degree female relatives have the BRCA2 gene positive, their risk for prostate cancer in their male relatives are significantly high.
When you say male relatives, do you mean their children, or do you mean...
let's say someone's mother has breast cancer, someone's sister has breast cancer, then that person needs to be vigilant about
prostate cancer. Wow, very interesting.
Yeah. So that's the relation of that BRC2 gene, and they reckon that, if someone has got particularly in certain ethnicities like the Ashkenazi Jewish people, the general risk of general public is around 12.5% in lifetime. That will go up to, if they have a first degree relative with BRC2 gene, then the risk increases to 27.5.
That's very high. That's very high indeed.
More than double.
That's really, really high.
That is correct.
Okay, so let's talk about ages. We know that, for example, colon cancer, bowel cancer, the age thing has been bust open, right? More and more younger people are being diagnosed with colon cancer, unfortunately. No one really knows why. Is it our more processed food? Is it microplastics? Is it? No one knows, right? But with prostate, I haven't heard much about the age recommendation changing significantly. What in your, if you were being sort of cautious, let's put it this way, at what age would you say men should start thinking about this properly?
If people want to be super cautious, probably we're looking at age 40 or thereabouts.
Okay.
The general sort of guidance is for high-risk people at the age of 45, and sort of low-risk people or people at sort of lower risk brackets, age 50, to start sort of screening and looking for symptoms and sort of examination and PSA tests and things like that.
That seems pretty reasonable and pretty vigilant, actually.
Yes.
And let's say you mentioned symptoms. Is it wise for us to get into symptoms of prostate cancer right now? Because we've talked previously about lower urinary tract symptoms in another episode, and I am aware that there's crossover, isn't there?
That's correct. So lower urinary tract symptoms may not have anything to do with prostate cancer. The sort of cancer of prostate usually happens in the periphery of the prostate, while the sort of tube which carries the urine out of bladder goes in the middle of the prostate. So you may have a peripheral lesion on your prostate, but have no symptoms, no urinary symptoms. That's why at certain age, whether you have symptoms or not, it's good to sort of do a test, do an examination, just to make sure that...
that's so interesting. I think, though, unfortunately, there are quite a few cancers that do not present with noticeable symptoms until they're pretty advanced. This is why there's such a strong argument for routine screening, isn't there?
Absolutely.
Yeah, so we're basically saying symptoms or no symptoms, don't wait to have symptoms, definitely not. Yeah. Engage with some routine screening, look at your family history, look at your other risk factors. What other risk factors should men be aware of, actually, for prostate cancer, if not genetics?
In terms of there are talks, I'm not sure how relevant that might be, but people who don't have regular ejaculations, they are thought to be at higher risk for prostate problems. So things like that could have some sort of effect as well.
Interesting, but it's probably affected by similar lifestyle factors as other cancers, right?
Not so much.
Oh, really? So even things like smoking and...
Smoking in general could cause cancer, and various different types, like bladder cancer, for example, is relevant to smoking and sort of contact with chemicals and that sort of thing, or lung cancer, for example. So smoking in general is something that I think should be considered as a risk factor to all
all things. But essentially what we're saying is that, because this is quite interesting as well, is that you're saying that prostate cancer, especially if you're genetically inclined, is a difficult thing to actively prevent, which is why the screening is so important, right? That's very interesting. So essentially, if it's gonna develop, it's gonna develop, and then you you need to catch it early.
Absolutely.
The prognosis must be much better with early detection,
Yes,
right?
much more improved compared to maybe 50 years ago, because the diagnosis is made quicker, the treatments are more advanced these days, and as a result, the outcome is much better.
Dr. Mohseyni, this has been really, really interesting. Thank you so much. And I look forward to talking again.
Thank you.
Thank you.